I
guess starting at the very top would be like the health science dean.
Well, no deans. Hospitals don't have deans.
Oh, I'm sorry, I thought you meant just at the.
No, hospitals don't have deans. Unless they're university-based hospitals, then you may have a health sciences dean or a medical school dean or something like that. I'm talking hospital in the community or a standalone centre. Who's in charge?
Medical director.
Hmm?
The radiation oncologist.
The radiation oncologist. Or at least he thinks he is. Or she is. Okay, so the radiation oncologist. What about administration? Who deals with that?
Chapter 1.
Who deals with administration? Hiring and firing and stuff like that. Who normally deals with that?
HR.
HR. So depending on the size of the department, you may have a separate HR department. Now, you could say that the HR department is on level with RADON. Don't ever let hear you say that, by the way. HR is sort of separate. So who's below the RADONC? So we'll call this the RADONC director. He's the boss. So below them, below him or her, you have other RADONCs. So you have a director who's a RADONC, a radiation oncologist, who's the boss, who may, depending on whether it's a standalone centre, he may actually be owner of the facility, or just the manager, director. So then you have the other RADONCs. Who's next? Who do you think might be next? There's usually, depending again on whether it's a hospital or a standalone centre, there's usually a director, oops, can't spell, or a manager of radiation oncology. So he or she is in charge of the technical staff, right? So what would the technical staff consist of?
Therapist.
Us, the radiation therapists, yeah. Who else? The nurses? RNs.
Dosimetrists, maybe?
No, not really, no. I will go back to that in a minute.
The physician?
Excuse me?
The physician? Like the doctor?
The physicians?
Yeah.
They're up here.
Oh.
They're below the RADONC director and above the manager or director. So why I said that the symmetrists are not included in this is you also have here physicist. So he's in alignment with the other RADONCs. And he would be in charge of the symmetrist.
Does the physicist also fall under the direction
Yes, yeah,
of top dog?
yeah. So that would be, he would be here. He would report to the doctor, the director. So you have the physicist, the symmetrist, you have the radiation therapist, you have the RNs. Who else might we have in the department? What other healthcare professionals might we have in a radiation therapy department?
The medical assistant.
Sorry, that's right. What?
The medical assistants.
What? Medical assistant? Okay. MA? Okay. They would be necessarily under the RNs. What else?
You have dietitians.
Dietitians, yeah. So we'll put them over there. What else? Who else? Oops. Social workers. Anybody else? Anybody else?
Safety officers?
Safety officers?
Yeah, like the radiation safety officers.
He would be a physicist.
Oh,
That would be part of his job in the department. What about,
Do we have our own cleaning staff? Janitorials, do they stay in our general department or do they?
if it's a hospital one, it's a hospital-based department, then they would be scheduled to the radiation therapy department. So yeah, so let's put them down here. So we'll count housekeeping. And if it's a standalone center, then they would be ours. They would be part of the therapy, yeah.
Is everybody under the director-manager considered support staff, or is that like just?
Support staff is usually a term which you would have for housekeeping, transport staff, security, anybody like that. The other ones, and perhaps MAs, but not really, the actual professionals, radiation therapists, dosimetrists, RNs, they're counted. Clinical staff. Support staff would be people like housekeeping, janitorial, security, that type of thing. And we have to add security too. That pretty well covers it. So, one more. In some departments, the therapists who are in CT, doing CT planning, are sometimes under the physicists. So we'll put CT therapists. So this is all really what we have to deal with. These are the people we have to liaise with, work with, interact with. Now there are a myriad different people here, and they all want the best for the patient. After all, without a patient, we'd be out of a job, right? So we have to get on with what we need to do. And we have to liaise and talk to and discuss and work with a myriad of different people. with differing points of view, differing attitudes, differing personalities. How do you deal with that? How do you deal with that? Think about people you've dealt with before. How do you get on with somebody that you have to work with or go to school with that you can't stand the sight of, but you have to work with them? That's what we have to do. It's easier in a large department because you can avoid certain people most of the time. Sometimes you really have to deal with them. But in a small department, where there's maybe only 3 therapists and 1 dosimetrist and a couple of physicians and maybe a couple of RNs, if you don't get along with a particular therapist, you still have to deal with them. You still have to work with them. That's where the healthcare professional comes in. And it's difficult. It really is. You can't very well say, I don't want to work with her. If you don't work with her, sorry, you can't work. You don't have to like the person you work with. You just have to be professional and work with them. Does that make sense? So what type of strategies can you find to work with somebody you don't really like? Anybody? Pardon?
Breathe.
You, basically you have to be, yeah, you have to be professional. Let's put it that way. You have to be professional. Even if it means that all you talk about is the patient. Your patient is why you're there. So you are professional, you treat the patient, you send them off, they're happy, they're on their way out. And then until the next patient comes, you sit and you don't talk about anything. You just sit there and do paperwork or do something else. And you just don't talk to them. You don't care what their weekend was like. As long as they show up and they're professional, who cares? Of course, that's not the way that you should be, right? You should be able to make the workplace relatively easy, relatively polite, relatively easygoing. The worst person I ever dealt with was a girl who used to bring her home problems in to the department. And, you know, she was having problems with a boyfriend at one point. You'll never guess what I did last night. I'm like, I don't want to know what you did last night. But she kept going on and on and on and on. And luckily enough, we had a relatively large department at that point. So I went to the boss and say, look, you know, this is not good. You either have to find a way to move her off the department, or I'm sorry, I have to move around and I was pretty high up in the hierarchy at that point, so I could do that. But this is being professional. You have to try to be professional. So what would you do if, I think I asked you guys this at your interview. So you have no, leave that for the moment. You have an RN who wants to see the patient. because he's having problems overnight. And the patient comes in and you say to them, well, how are you feeling, Mr. Jones? And he said, oh, I'm fine, thank you. So I hear the nurse wants to talk to you. Oh, why? I said, I don't know. She just heard you had some problems over the weekend. And he said, oh no, that's okay. So do you want to have treatment before you see the nurse? Oh, sure. So you take him in, you're halfway through treatment and the nurse arrives. And you can tell she's miffed. She's angry. Why didn't Mr. Jones wait to see me before he Because he said he was fine and he'd like to have his treatment before he sees you. But that's not the message I gave you. Look at the screen. Please let me see Mr. Jones while he's here on treatment. You didn't say, I must see him before. You didn't say, please don't treat him until I see him. Men didn't mention that, so we just followed our professional, technical guidelines, and we treated him. And she stomps away. Fine. Is that professional? All she had to come and say was, oh, you treated Mr. Jones. Why? Well, he was feeling fine and you didn't specify whether you want to see him before or after, so we used our technical judgment and treated him. Oh, okay. Well, I'll just hang on and wait to see him after. Okay, that's fine.
So she stomped away from you?
Yeah. Literally stomped away. You know, all the way down to the nurse's office.
That takes a lot of effort.
That happened to you?
Pardon?
That happened to you for real?
Well, you know, I mean, you can only do what you can do. We had when I was working in Kentucky, in Louisville, I was the manager. And we had an ongoing feud between the nurses and therapists. And they didn't talk to each other. They sent emails back and forwards. That was it. Nobody talked. Which is bad patient care, because you have to liaise with each other. And it made the patients feel a little uncomfortable. And you have two healthcare professionals supposed to work together, not talking to each other. And the patients were noticing it. So we decided that enough was enough. So what I did was I asked for one RN and one therapist. They could choose who they wanted to get. And they come up to a meeting. So the two of them came up and the nurse came up and said, come into my office. And the pair of them are sort of standing there looking at each other. You could tell, you know, if looks could kill. So I said, okay, let's go into it. And I sat there at my desk. I sat behind my desk and the pair of them sat there. And I said, okay, talk. You're gonna stay? Mm-hmm. And I said, as long as you don't throw furniture. Anything that's said in this office stays in this office. So the first thing they did was start hurling insults at each other. The door was closed. And after an hour, they had gone out and off their chests and everything. And at least they were talking to each other then. So they went back to their relative camps and told them what they had decided. And everything was, I would say it was great, but they were talking to each other after that. That's all it needs, is a little chat. a little talk. If you don't think that the person you're dealing with is not being professional, then you have to say something. And if you're not comfortable with saying something to them, say something to your supervisor, which in your case would be me. If you have a problem with one of the staff members in the department, come to me. If they have a problem with you guys, I can assure you they come to me. Not that I have it very often, but we have a couple of months to deal with that because you won't be going into clinic this semester anyway. So we have some things to deal with. So for example, why do we need social workers? Why do we need social workers in the department?
Because the patients are dealing with a lot of different stuff, finances, their support at home, their own emotional dealing with having cancer to begin with.
Right.
There's
Yeah.
lots of things that social workers could help guide them to
Yeah.
for help.
Exactly. So you have social workers who can deal with a myriad of problems that we don't have the time to deal with, because a lot of this stuff takes time. And we don't have the knowledge of the stuff that's out there that they can collect and give to the patients. So things like transport to get to the clinic. Somebody to come in and look after the house once a week or so. Take care of them, take care of the house. Take care of them. If they're not doing too well and you notice that they're not having showers, or they're not clean, or they're having problems with their mental health, then that's something else. A lot of departments have what they call psychosocial workers or psychologists. You're great if you have a psychologist in the building. They are wonderful if you have one. They deal with all sorts of weird and wonderful things patients come up with. So what about dietitians? Now we know that the nurses will deal with with diet and food. We can do a little bit with diet and food. Why have dietitians?
It's good to have people that are specifically trained to deal with
Yeah.
issues and things like that, especially
Yeah.
if you're going through treatment.
Yeah, so you have people who are skilled in, for example, when we were doing with GI. And we were talking about a high fiber diet or a low fiber diet. Low fiber diet means that you can have what? What does a low fiber diet mean? What can't you have?
Apples.
Apples?
Lots of apples.
Apples, okay, what else?
Whole grains?
Whole grains, veggies, everything that is good for you, you literally can't have. So what do you do with a patient who's a vegetarian, or even worse, a vegan? And you tell them that they can't have whole grains or vegetables.
They probably have to go on a pretty rigorous diet, or I mean, not rigorous, but like vitamin recommendations.
Yeah, so that's where the dietitians come in. You have people who are how shall I put this, not mainstream as far as their diet goes. I know that's terrible because a lot of people are vegetarian, but they're not, they don't have the same dietary requirements as most of the population. So you have to know, you have to get these professionals and say, look I have this poor woman who's vegan. We told her that she had to go on a low fiber diet and she's panicking because she says she can't eat anything. So she takes her to her little office and she gives her some pamphlets and stuff of what she can do. And she may work out a diet regime for her. And that's purely for her. And she'd tell us, she'd send the diet regime to us as well, so that we know not to put our foot in it and say, look, can you eat this stuff? And you look on it and you can't eat that because she's vegan. Does that make sense? Okay. So, housekeeping. They're people who usually come in the evenings, you don't see them very often, but they keep the place clean. Except that most departments will not allow housekeeping to clean in the treatment room unless specifically asked to do. So if you make a mess in the treatment room, you guys, everybody, I'm not talking students, depending on how your therapists work. The therapists and or the students have to clean it. Although in some cases, housekeeping will be called. But remember, you have a 15-minute time slot for each patient. For example, 15, 20 minutes, depending on what you're treating. You cannot wait a couple hours till housekeeping come down to clean whatever mess it happened to be. For example, patient's asked to have a full bladder for prostate, right? What happens if he can't hold it? He pees on the bed. Who cleans it up? We do. You have a patient who is a rectum. He has a colostomy bag. You're treating him prone. His colostomy bag bursts. Who cleans up? We do. It's not something that we like. It's not something that we really want to do. But that's us being professional and continue. So, how do you clean this stuff up? Without all the COVID stuff, just we'll do it normally. So, we'll give you a nice example. The patient pees on the bed. How do you clean it up? What do you use?
Is it during treatment when he pees on the bed, or do you find out after?
Find out after usually. You usually walk in the room and he said, I'm sorry, I couldn't hold it.
And you go, oh.
Sorry about that. So what you do is you send someone to get a pair of scrub pants or something and give him that to go home with, because his underwear and his pants, if he's still wearing them, are wet. Give him a bag to put his stuff in. And then you get him off the bed, you have a soaking wet sheet and a wet bed. These beds are carbon fiber. So what do you do? How do you clean it?
How about remove the sheets, get those cancer wipes?
You basically get a pair of gloves on and you You take the wet sheet. Now, depending on the rules and regulations of the department, you sometimes have a bag, which is a biohazard bag, which you put soiled laundry into. So you put it in the soiled laundry. If you don't, and if all the laundry is counted soiled, then you put it in the laundry bag, whichever laundry bag happens to be there. Then you're left with a wet bed. What's the ideal thing to use?
Do we have like an absorbent powder or anything to help absorb the liquid up?
Nope,
Paper towels.
Disinfectant wipes?
disinfectant wipe or bleach. Usually we use bleach.
Love bleach. Bleach works.
The problem with bleach is, in any of the disinfectant wipes, is, and the disinfectant wipes are so small that you'd probably just use the bleach and, like, so you wipe it off. Then what?
With it.
Yeah.
For the sheets.
I mean,
Get fresh
depending
sheets.
on how much I guess they urinated, would there be some on the floor, can that come off the bed?
Yeah.
You get to clean that too.
Yeah, so you get the bleach and you clean the floor. The thing about it is, if you use bleach, you should wait for 10 minutes at least and let it air dry. And then you can use water and just clean it and then dry it off. That's the problem with the bleach. And with any of the disinfectant wipes, you should leave it to air dry. You don't wipe with disinfectant wipe and then just dry it off. That's not. So you've wasted, I shouldn't really say wasted, but you've wasted 10 minutes. You have 15-minute slots. Your patient takes 10 or 12 minutes to treat, but he peed on the bed, so you've wasted 10 minutes or 15 minutes, depending on how long it takes you to get the patient up and get him decent with a scrub top or whatever it happens to be, or scrub pants or whatever. And get him out of bed, out of the room, and then clean up. Because you don't want to start cleaning up while the patient's in the room. Why not?
They probably feel bad.
Yeah.
They make them feel like,
As if he doesn't feel bad already, it'll make him feel even worse. So we want to be extremely sensitive to these guys.
Are there not time gaps in between treating patients to reset the room? Or
You're
is it back to
resetting
back
the
to
room as the one patient is going out of the room, and you send someone down to get the new patient from the waiting room. While that's happening, you're resetting the room. So you waste no time whatsoever. Because if the patient takes 12 minutes to treat, from the time he walks in to the time he walks out, and you have a 15-minute slot, you don't have a lot of time. And if you waste that time, then you run behind all day. Because 99 times out of 100, you don't have a break for lunch. You work through lunch. Not you, but the machine works through lunch. If you're lucky, you can stop the machine for lunch, but 9
So
times
they're
out of
like
10 you
really
can't.
like on top of each other, so if something comes up, you better have more than one machine
Yeah.
to use?
Well, no, not
You just
necessarily,
get
you
behind
see.
and deal with it?
Yeah, you get behind and deal with it.
would you just tell the next patient, hey, I'm sorry?
Well, what
have-
we tend to do is, if we're running significantly behind, by that I mean, more than about 10 or 15 minutes, we let the patients know. So one of the staff will go back to the waiting room and make a general announcement. I'm sorry, the Linac one is running half an hour behind. And all the guys who have full bladders go, whoa. So, yeah, you have to let them know. It's good patient care. Although sometimes you just can't avoid it. The, one of the departments, the Proton Center at UF downtown, they have an electronic board for the proton machines. They've got 3 proton machines. And if they're running behind, it comes up on the board. Proton 1 is running 30 minutes behind, Proton 2 is running whatever. The last time I went down to visit some students down there, one of the proton machines was running 2 hours behind.
Oh my gosh. How often do things get behind? Like once a week, once a day, once every 2 weeks?
It depends. Normally if you had to pick a day that you may be running behind, it would be probably on Monday. Because a lot of times the patients have got problems over the weekend and they want to tell you all about them. And although what we do is we walk and talk, we get the patient out of the waiting room and we're walking them down the hallway and we're talking to them all the time. So how was your weekend? Any problems, etc., etc., etc. And by the time you get into the room, you know exactly what the patient has been having problems with, or no problems at all, over the weekend. So, although you get some patients who, if you ask a question, will stand, will stop, and they'll talk. And then you walk them further and you ask them another question and they'll stop. So the idea is that you keep them moving. Come with me, Mr. Jones, we'll get into the room, but we need to chat as we go. Oh, okay. But some people just cannot walk and talk at the same time. They need to stand there and talk, which is a bad thing sometimes. So that's probably a Monday would be worse. Although patients can come up with problems every day of the week. Sometimes the same patient every day of the week. But that's probably the most common day. If we're gonna have problems, it's with patients, it's usually on a Monday. And then the physician needs to see patients once a week. So depending on when he sees them, we may have to chat a little bit more to find out if they have any problems for the physician. Because we need to write a note so the physician can look at that note and say, oh, Mrs. Jones, I hear you was having problems over the weekend. Tell me about it. Or you're in the insane thing that, oh, Mrs. Jones comes in and says, and you ask them how the weekend was. Oh, I had terrible cramps and I had diarrhea and I was feeling nauseated and yada, 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 on and on and on. So you write a note for the physician and he's seeing her in the morning. She gets into the room and the doc looks at your note and says, okay, Mrs. Jones, how was your weekend? Oh, it was fine. And that's the thing about writing a note. So he can say, well, the therapists were saying something about you having a bad weekend, you were having cramps and diarrhea, and oh yeah, I guess I was, but you know, well, why don't you tell me about it? Oh, you're so busy, I didn't like to disturb you about that. Okay.
So like that's not their job.
Yeah, oh yeah, totally. But at least you wrote a note and he knew about it. It would be more difficult if you didn't write a note and he found something wrong that you didn't ask them about. How are you feeling? Oh, I'm feeling dreadful. Well, Didn't you let the ladies know in the machine? Well, yeah, well, no, they didn't ask me, so I didn't tell them. So the other thing that can cause problems with your machine schedule, what do you think the other problem is? Apart from the patients.
Maintenance on the machines?
Not so much maintenance on the machine, because the maintenance on the machine are usually scheduled.
Operative error.
Operator error? No, not operator error. Just faults on the machine. There are certain faults that come up on the machine that we can clear, that we have got training, that we look at the fault and say, okay, this is one of the ones that I can clear, depending on your level of knowledge. So you clear it, but you write it down for the physicist, who's ultimately in charge of the machine, and say, well, I cleared, there was a dose 1 or whatever it happens to be on the machine, but I cleared it and continued and everything was fine. However, if there's a major problem with the machine, you remember we were talking about the multi-leaf collimators. The multi-leaf collimators go in and out. They each have their own little motor. What happens if one of the motors doesn't work? Then that leaf doesn't move in or move out, whichever it happens to be. And if one leaf doesn't move, then the shape of the beam, which is on the plan, which is in the software, won't work. So the machine will not switch on. Because everything goes, when you have an MLC shape, depending on the type of machine you have, it will go green. If there's a problem, it will stay red. So everything is red until the shape is correct, then it goes green. If you have one little leaf that's out of sync, it'll stay red. You cannot treat. So, you have to change the motor. The person who usually changes the motor, depending again on the department, is usually the physicist. So he will come in, he'll say, what's wrong? Motor stuck. Which one? Leaf stuck is what it usually says. Which one? So we tell him which one. And he says, okay, give me half an hour. So you get the patient you've got on the bed and say, I'm sorry, Mrs. Whatever. We have a mechanical problem with the machine. The physicist is here to fix it. Give us 20 minutes, half an hour. Okay, so she goes back to the waiting room. And then all the waiting room knows, because I just broke the machine. That's usually what happens. So usually one of us goes back and says, it's just a mechanical problem, the physicist is working with it. We'll wait half an hour before we can start. So that means you're half an hour behind, unless you have a break for lunch. But you're still half an hour behind until that break. So everybody that comes in usually gets told by the person who's sitting there saying, the machine's half an hour behind. Yeah. So what do you think that patient feels when she comes in and she's on time or a little early, to be told by one of the other patients that the machine's half an hour behind? Frustrated, annoyed, angry. Oh yeah, we've had a few angry. But there's not a heck of a lot we can do about it. The machine
Sorry.
doesn't.
Sorry.
Yeah, well, you can only say sorry so many times. So what we tend to do is one of us goes up to the waiting room and explains that we're half an hour behind and it's just a mechanical problem. And we usually explain that one of the little leaves that they see, and you can actually see them as you lie on the machine, you can actually see the leaves. One of these little leaves is not functioning, so the motor has to be changed. Usually they understand, but they're still a little upset.
How often does that happen, where you have a motor issue on the leaves?
It can be months,
That's not bad.
and then you have maybe 3 in a 2-week period. You know? It's like anything mechanical. They're very intricate machines. The more bells and whistles that you put on the machine, the more things there are to go wrong. So these are very intricate machines. There's a lot of bells and whistles. You just have to be capable of working with your patients and keeping them sane and calm, or as calm as they can be. So you have a patient who is supposedly next in line, but he's got a full bladder and you know it's going to be half an hour. What do you do with him? What do you do with them?
I think you'd have to let them go to the restroom.
Yeah, you do. Tell them to go to the bathroom, tell them to go to the restroom, and then start drinking again. Because normally it will take 20 minutes or so for the water that you drink to reach your bladder, depending on the person. 20 minutes to half an hour before the water reaches the bladder. And we have to have a full bladder for these guys.
Is the physicist typically always on site for stuff like this, or is there a waiting period if something goes wrong that you have to wait for them to come?
In most cases, the physicist is there, and that jumps to the top of his list. If we have a problem in the machine, that is the top of his list. The patients come first with everybody. If, however, your department has a main building and a satellite, maybe a couple of satellites, and the physicist moves between the departments, then you may not have a physicist on site when something like that happens. The other thing that could happen is that the management of the facility, whoever that happens to be, has decided that the physicist will not do that. They will call the engineer from the manufacturer. Unfortunately, if you're really lucky, you have one of these engineers in the city. If you're very unlucky, you have one of them that's 2 hours away. So you may be down for the afternoon, which adds to the chaos. So what, say we have a major problem and the physicist looks at it and says, call the engineer. So you call the manufacturer and speak to the engineer and explain what the problem is. And he said, okay, I'll be out. And the first thing out of your mouth, because you know the doc's gonna ask it, is how long till you get there? Well, for example, if you are here in Jacksonville, the engineer may be in Gainesville, which is 2 hours away, approximately, depending on where you are in the cities. So you're 2 hours down until the engineer gets there. So if this is lunchtime, your first patient, and this is 11:30 when your machine goes down, you've got till 1:30 till the engineer gets there. And then he has to find out what's wrong, and then he has to fix it, so you're probably down for the afternoon.
In which case you do what with your time as a therapist?
You first of all call the physician, call the patients. Your afternoon patients have to be contacted. And tell them that, well, before the patient's contacted, you call the physician and say, what do you want to do? Now, this is all presuming that you only have one machine. If you have two machines, then you might be in luck. But one machine, you have no other way to treat the patients. So you have to give them the afternoon off. So it's you guys, or the therapists, that have to call the patients by the physician's request and say, I'm sorry, we have a problem with the machine. It's going to be down for the rest of the afternoon. So we'll see you tomorrow at your normal time unless you hear otherwise. Which means you're hedging your bets just in case it's not up by tomorrow. Because he may have to order a part, and that could take another 12 hours.
So I
it's-
mean,
okay.
is the physician gonna get in trouble, would the radiation oncologist get in trouble for them missing their treatment like that, or are they gonna work around it, or?
Well, what they normally do is, that's one thing that comes up all the time. The patients will say, well, is that gonna cause problems with my treatment? And normally the physician would say, no. Missing one day is not gonna harm you. Missing a couple of weeks, yeah. But missing one day or even 2 days is not gonna harm you. But they may decide that once the machine is up and running, that they may treat on a Saturday
Make up for
to make up for the day that they've missed. So that's what a lot of them will do. But we can assure the patients that it doesn't affect the treatment. The radiobiology thing comes into play. But if we can get maybe a Saturday or a Sunday that they can come in and treat or have treatment, then we're back to where we were. Remember, most departments, they'll give patients days off during July 4th, Memorial Day, Christmas, Thanksgiving. This is all built into the treatment. So one extra day is not gonna have a problem. Most physicians will say that they must have patients treated at least 4 days a week. So if your machine is down for 2 days, the patient may only have 3 days a week, or 3 days that week of treatment. Therefore, they may decide to treat on a Saturday. And if you come in on a Saturday to treat, then they normally give you time and a half, because you're coming in on a Saturday. Which costs them, of course, money, but then the breaks, unfortunately.
I have a question about the dietitians.
Yeah,
So when it comes to that, are the dietitians like specifically in our department, or do they have, like, do they only work for our radiation therapy department, or do they, because I know you said they had an office, or some of them do, so do
well, again, it depends what kind of department you have. If you are in a standalone center, then you may or may not have a dietitian and a social worker in the department who are owned by the department. If you're in a hospital setting, then it's probably the hospital social workers or the hospital dietitians that will come and work. But there is a possibility that in one of the departments I worked in, which was a big hospital department in California, we had a dietitian on staff who was radiation therapy, and she was, she had a specialty in radiation therapy dietetics. And the social worker also was specialized in radiation therapy patients. So if you're lucky enough to have something like that, then that's ideal, but you could just have someone come in from the hospital, the local hospital, and do the dietitian thing as well. Does that answer your question?
Yes, ma'am.
Okay. Yes, ma'am.
Were you forced to move so much?
Pardon?
Were you forced to move so much? Like, you worked like all over the country.
No, I,
Like Kentucky, California,
I've worked in 3 different countries and various places.
by choice.
By choice,
Okay.
by choice, no. I trained in Scotland. I worked in London and back in Scotland. So, and then my program manager, you would call it here, was one of these people that thought that working abroad would broaden horizon, if you pardon the pun. And so she's decided that, you know, all of our students should work abroad for a couple of years. She didn't specify where. She worked at Princess Margaret Hospital in Toronto, and she worked at Sloan Kettering in New York. So she thought this was great. So I decided that I would work, and when I was training, it was a 3-year program, and I was right out of high school. So I was young, really young. And so I got my first job just after my 21st birthday. And then I decided that I would go abroad when I'm going to age myself now. So that would be 1980 or 1979 actually. And so I wanted, and my language skills weren't that good. I know French, but apart from that, bleh. So I had to stick with the English-speaking world, which would be Australia, New Zealand, South Africa, US and Canada, basically. I was still living at home. Well, I wasn't living at home actually, but my mother decided that Australia and New Zealand, although I had relatives in Australia, was too far. So I thought, okay, mother, yeah, fine. So I was stuck with South Africa and North America. South Africa at that point was still under apartheid. So I said, not South Africa, because I'd probably say something, put my foot in it and get thrown out. So Australia, and so that left Canada and the US. In the US, I looked at, and I had friends in the US, and they had told me all about the system. And growing up and working in the British system, I didn't like the sound of the US system. So I came to Canada, and I told my mother it would be 2 years. 20 years later, I'm still there. At that point, I had got married, and my husband is a US guy, so he decided that after 20 years in Canada, we would move south.
South. South.
South, yeah, south. Well, not quite south. I haven't got to Florida yet. So, for 20 years, I was in Calgary, which is in the western portion of the US. If anybody is old enough to remember, they had the Winter Olympic Games there in 1988, and it was wonderful. It was great fun. Both my husband and I volunteered. It was great fun. Anyway, so I moved from Calgary to El Paso, Texas. And I moved in January one year. That was 2002.
That must have been a culture shock.
Yeah, more ways than one. When we left Calgary, it was -20 and 3 feet of snow on the ground. And I got to El Paso and it was 65 degrees. Wonderful. Everybody running around in parkas because it was cold. And I'm in short sleeved shirt and my husband's in shorts and we're wandering into Walmart and everybody's looking at us and thinking, oh, place did they come from, you know? And so I worked there for several years and then I got the option of taking a manager's post in Louisville, Kentucky, which I did. And then we moved to Florida. Not South Florida. And unfortunately, then the problems hit with jobs and I was laid off. So I got a manager's post in California, in a place called close to Palm Springs. It's called Rancho Mirage. Right in the middle of the desert. Hot. When I moved there in August, it was 120 degrees. Yeah. I worked in a place called Eisenhower Medical Center. It was famous or notorious, I guess, I'm not sure what you would say, for the fact that it is the place where Betty Ford Center is located. Everybody know what I mean by the Betty Ford Center? It's the place where well-known people go when they're addicted to whatever they're addicted to. Drugs, alcohol, whatever it happens to be. So it's on the campus of Eisenhower Medical Center. Very nice place, but hot, very expensive. Lots of very well-known people there.
So, what does your husband do for a living?
Well, he usually stayed where he was put, actually. He actually did, he is, at that point, he had his own software company. He did high security software. So a lot of it was done, all of it was done on the computer. So he didn't move to California with me. He doesn't like California.
I don't blame him.
I don't particularly like California either, but the job was there, so I thought, what the heck. I stayed there for 2 years and then moved to Jacksonville to get this job. And I've been here ever since.
What made you want to teach?
I've always taught. I did, all through my career, I did clinical teaching. I did clinical observations and stuff, so I've always taught in the clinic. And then somebody said, well, let's give you a class to teach. And I don't want to do classroom work. And I did it and I thought, this isn't so bad, maybe. So when I came for my interview here, Dr. Henning, have you all met Dr. Henning? He'll probably pop in today, usually does. He's the Dean of Health Sciences. And he was interviewing me, and he said, you know that you're interviewing for program manager? Yes, I know that. And he said, do you have any questions? And I said, well, yeah, how many people do I have on my staff? And he said, well, there's you. And there's you. And I said, you're trying to tell me that I'm on my own? And he said, yeah. Okay. So, so my job is to basically do everything that is not done in clinic. And this semester, that includes clinic as well. So on Wednesday, we will be doing some stuff a little bit here, and then we'll go upstairs to the lab. It's actually the radiology lab because one floor up, and we'll do some more stuff. And that'll give you an introduction to the actual clinical side of the treatment, okay? Any questions about the clinic per se? Or the radiation therapy area?
Not pertaining to that exactly, but I did have, so you work in a lot of places. Do you have a specific place where you liked your work the most? Like, was there one that stood out that you liked living there and working there, and it was just a good environment to be in?
Yeah, Calgary.
Calgary.
Calgary, yeah. It was a big department. We moved, just after I got there, we moved into a brand new purpose-built center. We had, when I left, there was 10 machines. There was probably about 50 therapists, plus 10 dosimetrists, plus 8 radiation oncologists. And it was a big family. It really was. It was a big family.
Good people to be around.
Good people to get around, yeah. And we had all sorts of different patients. We were affiliated with medical school. We were affiliated with, we were part of, but slightly separate. We were in the same campus as one of the hospitals, which again was affiliated with the medical school. The medical school, we were at one end of the campus, the medical school was at the other end of the campus. So it was really good. We did lots of clinical. That's probably the thing that I didn't like, was the all of the clinical research that we did. We had a lot of patients on different types of clinical research and stuff, so that was a lot of work. But we were known as one of the best centers in North America. They still are. So it was good to work there. But it was a huge center. And I went from that to a center in El Paso that had 2 machines. So it's actually better, I think it's easier to go from a large center to a small center than to go from a small center to a large center, because the politics in a large center can be overwhelming if you're not used to it. Yeah. So let's take a break. This is something I can do now, not be able to do when we were on online. So let's take.
Is any of this stuff, gonna be on campus? Cause I'm looking at my dashboard and
There's nothing in Canvas. No,
Okay.
no, there's nothing in Canvas.
So closely. So will we get these?
The courses are up.
Oh,
Yeah, they are up. I will put all these PowerPoints into Canvas. Okay, so vital signs. So what are, I should have asked this before you started. Okay, so vital signs: temperature, pulse, respiration, blood pressure, and oxygen saturation. So if I asked you to take a pulse, where would it be? How would you take it? Where would you take it? On a normal person, where would you take it?
Radial.
Wrist. Okay, anatomically, where would you take it? Where is the pulse on your wrist?
On the thumb side.
Pardon?
On the thumb side.
Yeah,
When your wrist is
Radial.
thank you. Radial artery. Right here. Okay? You should be able to feel it on yourself.
I always do mine.
It's more difficult to get your pulse on a normal person, on a normal, healthy person on this one. If you raise your chin up, you can feel it better. But it's a lot easier on an unconscious person.
Yeah.
You raise your chin up, you can feel it. So, your radial, which one, what's this called?
Jugular.
Pardon?
Jugular. Carotid.
Carotid. Okay, where are the other ones you can take?
Femoral.
Femoral? Okay, a little difficult, but yeah. And it looks very weird if you're doing it on a normal person because it's right in the air and it can get rather interesting. Interesting. Where else? Where do you take it on an infant?
I thought it was
Under their
femoral.
arms or?
Oh, brachial. Needed brachial?
Brachial. So where's the brachial pulse?
Anticubital, antecubital?
Yep. It's right here.
Same place you do the BP.
Same place you do the BP.
I've seen this so many times, I didn't even know.
Yeah. So the most common one is just to take the radial. It's a lot easier on most people. So what do you need if you're going to take a radial pulse or a pulse?
A second hand. A second hand on your
A
watch.
sweep hand, yeah, a second hand on your watch, or a watch which gives you seconds. So therefore, if you're taking this on yourself, you have to do it this way. So you can't really do it this way and do this, you know. So you need a second hand, a watch with the second hand on it. Why are you doing it that way?
Can't use your
How
thumb
do you
because
take-
your thumb has a-
Your thumb has a pulse of its own. So, to take, I thought everybody knew this. Okay, let's go back to the beginning. How do you take a pulse? 2 fingers. Find your pulse. Find it on yourself. Everybody found it? Keep your thumb out of it. Keep your thumb out of the way. Everybody got it? Okay. Good. Okay. So how long do you do that for?
Technically 1 minute.
Technically 1 minute.
30 seconds times 2
Well, yeah,
when you're rushed.
technically 1 minute. So if we're doing it for 30 seconds, what else should we be doing for the other 30 seconds?
Time respiration.
Respirations, because if you are telling your patient that you're gonna do respirations, what are they gonna do? Yeah, so the idea is that you take the pulse for 30 seconds And then you just keep your fingers there and just watch them. Or talk to them if you can do two things at once. Watch them breathing in and out for the other 30 seconds. And you can do your pulse for 30 seconds and double it. So what should the pulse be in a normal, healthy adult? There's a range. There's a range.
60 to 70 resting,
Say again?
60 to 70 resting. That's low.
Pulse?
70s to 90s.
Yeah, well, again, it depends on what your individual is. If normally it's about mid-60s to mid-80s, but you have some of these extreme athletes that their pulse could go down to 50. So anywhere around 70-ish is a normal pulse. 68 to about 78, something like that, but there's a range. And some people are at the low end of the range, and some people are at the high end of the range. But whatever's normal for them, basically. So that's pulse. Respirations we went over. What else is there?
Temperature.
Temperature. Okay, here's a goodie. Okay. What is a normal temperature?
Orally,
I didn't say anything. What is a normal temperature?
98.6.
98.6. And that is where?
Thought that was orally.
Okay. So, same as pulse, you can take temperature in different places. Where's the normal place you take it? Orally. With a thermometer. How do you take it orally?
Under the tongue.
Under the tongue. Right, okay. So if the patient is not compos mentis, as it were, patient is not, you don't think you would do it orally because the patient might clamp down on the thermometer. Where else can you take it? Axilla. And? Rectal. And? Pardon? The groin? Okay, yeah, but not usually. Your forehead. Where else? There's one more, one miss.
Ear.
Ear, yeah. So where would you, which type of person, which type of patient would you use the ear primarily?
Kids.
Hmm?
A child.
A child, yeah. Also the forehead, the little thing that you put on the forehead. Yeah. The axilla sometimes is not good for a child depending on how mobile they are and depending on how competent they are. You could do rectal in a child, but usually it's easier to do the ear. It's easier anything than the rectal. Which is the most accurate?
Rectal.
The rectal, okay? Blood pressure. How do you take a blood pressure? And don't tell me you use the mechanical thing that clamps onto your wrist or, and then, no, we don't do that. We need to do the old-fashioned way. So what is the equipment needed? So you said the stethoscope, yes.
And a timer. Didn't use it. I think my professor had a timer in anatomy here, he did mine.
Okay. What is the equipment that you need normally to do a blood pressure?
Your pressure cuff with this sphygmomanometer thing.
Sphygmomanometer.
Yes, that thing.
Yeah.
And the stethoscope.
BP, well, the sphygmomanometer is the
Gauge.
is the thing that shows you what the blood pressure is. The cuff is another thing. So the one thing you have to make sure of with the blood pressure is that you have to have the correct size of cuff. If you're slim, then you may use one type of cuff. If you're a big linebacker type guy, then you may have to use a double XL cuff. Normally there's a medium and a large, and then there's usually pediatric. But most people nowadays use the electronic ones. That's fine. The majority of the departments would have one like that, but it doesn't matter. You still have to learn how to do correct way. And we will go over that probably on Wednesday or another day. Okay. So let's go on to my little spiel here. Okay, so why do we need vital signs? Well, they're important indicators of the body's response to physical, environmental, and psychological. Temperature. If you have a high temperature, what does that mean, usually? Pardon?
Body's raising temperature to fight off some kind of sickness, pathogen,
Infection, maybe?
infection.
Yeah, okay, yeah. What about, a pulse that's high?
It could be nervous.
Yeah, like if you go to the doctor and your pulse goes, yeah. Or your blood pressure does the same. And you know what that's called?
White coat syndrome.
White coat. What?
Syndrome.
White coat
Syndrome is another name for it. White coat, something else.
It's the only one I've heard
That's
of.
all of them.
What is high blood pressure called?
Hypertension.
Hypertension, yeah. White coat hypertension is what it's called. Every time you walk into the doctor's office, your blood pressure goes. Okay. So, vital signs may reveal sudden changes in condition, in addition to changes that occur progressively over time. So, this is, by the way, a medical assisting, for medical assistants, so we'll just look at it. Before, after, and during maintenance interventions. So, we want to continue with the physician's order. Physician's standing order could be that the patient has his vital signs treated done once a week. We can do that. We're allowed to do that. If there's a nurse in the premises, they usually do it, but we should be able to do it as well. If the person, the one time where we would probably need to do that as a routine would be if the person has a pacemaker. If patient has a pacemaker, then there's what's called a pacemaker protocol. And that means that you would have to make sure that the pacemaker is working. The easiest way to do that, can anybody tell me? Easiest way to make sure that the pacemaker is working.
Take your pulse.
Take the pulse, yeah. So what we do is you take the patient in, lie them on the bed, let them relax for a minute or so, take the pulse. Write it down, the reading, and then once the patient has been treated, before you get them off the bed, you take the pulse again. And it should be the same, or give or take a couple of beats. If it's way out, then you may have a problem. The one thing that we have to remember is that the same person takes the pulse both times. Why would that be?
People do it different.
Yeah, I mean, if I took somebody's blood pulse and I say it was 72 and somebody else took the pulse and say it was 74, it's not different, it's not that different, but it's different. So one person should take the pulse before and after. And that's a minimum pacemaker protocol. In some departments, it would mean doing blood pressures before and after. And that usually is the nurse's problem. So, skin temperature rises and falls. So the body's tissues and cells function best between the range of, and here we get into Celsius, 36 degrees C to 38 degrees Celsius. Anybody tell me what the normal temperature is in Celsius? It's approximately 37. Temperature is lowest in the morning and highest during the evening. But you didn't know that. Okay. So, 3 types of thermometer. Glass, although we don't use much as mercury anymore. Electronic, which is basically what we use these days because you take it out and stick it in the pump. The disposable plastic covers for each relies on battery use. Everybody's had one of those done, right? You take it out of the, right? Okay. Oral or auxiliary. And obviously a different one for rectal. Yeah, okay. One would hope that would be good, yeah. So red for oral and auxiliary, and blue for rectal. And infrared, that's the one that does the ear. And also that's the one that does the forehead to check the temperature, which I should have done this morning. So here is a little site here. So oral, posterior sublingual pocket, under the tongue, close to the carotid artery. No hot or cold drinks or smoking 20 minutes prior to temperature. Must be awake and alert, not for small children.
3 minutes.
3 minutes, yeah, officially. How many people have seen that done, 3 minutes?
One time.
I don't think
No.
I've ever seen that.
No,
I don't think I
that's,
can handle that. That would drive me insane.
That can really take longer when they have a higher temperature.
well, I think this is just, this is something in practice, we don't do it for that long.
Maybe the mercury ones took longer?
The mercury ones do take longer, but there's no mercury ones left.
Right.
So, yeah. So the other thing is that if you've noticed, in most areas, they do the temperature at the same time as the blood pressure. The blood pressure takes 2 or 3 minutes. So they just leave the temperature in at the same, the thermometer in at the same time, so. Electronic leak sensitive probe. Again, disposable plastic cover, so this is the one that everybody's used to, so that's why it doesn't take 3 minutes. and the infrared one. So non-invasive, good for children, less accurate. Rectal, when unsafe or inaccurate by mouth, lying on side position with the knee flexed, so if you really want to know that. Measures 0.5 Celsius higher than oral. And the ear goes to hypothalamus. So if you're doing the ear, the adult, you pull the pinna up and back. For kids, you pull the pinna down and back. So 2 to 3 seconds in the ear, 2 to 3 minutes rectal, 5 to 10 minutes in the axilla, and oral, 3 minutes. Okay, radial pulse. So we have carotid, brachial, radial, femoral, popliteal, posterior tibial, and dorsus pedis. So, popliteal, where the heck's that?
On the kneecap.
Behind the knee, yeah, right here. Posterior tibial and dorsalis pedis. Any ideas what that is?
Is that the back of the foot, kind of right where the ankle is?
Yeah. So you want to, when you're doing the pulse, you want to assess the rate, the rhythm, and the strength. How do you do that? Well, the rate is the amount of 68 or 72 or whatever it happens to be. The rhythm. What do you mean? What do they mean by that?
They have a pacemaker, they skip a beat.
Okay.
You don't really feel that beat that they pick up.
But if you don't have a
Consistent rhythm.
pacemaker,
You just build a consistent rhythm that's not jumping or
yeah, if you're reading the pulse and it's nice and even and steady and routine, that's normal. But if you get 1, 2, 3, 5, 1, 2, 3, 4, and a little break, and then you go back to,
that's no good.
and strength. If you have a very strong pulse or a weak pulse. Pulse deficit, difference between the radial pulse and the apical pulse indicates a decrease in peripheral perfusion from some heart conditions. Where's the apical pulse? And how do you read it?
Is that with the stethoscope over the heart?
Yeah, and you need a stethoscope to do that. You need a stethoscope to feel that. So, peripheral. Place third, 2/3, second, third, and fourth. I usually use 2, it's easier. Likely on skin where an artery passes overlying bone. Do not use your thumb. Count 30 seconds times 2. If irregular, count radial for 1 minute, then apical for a full minute. We would not use apical. That's something that the nurses might use or the physicians might use. We would not go there. So you use 30 seconds and then check respirations for 30 seconds. So there's your lumped up. Okay, so 60 to 100, the average is 80 beats per minute. Tachycardia or bradycardia. Tachycardia means that the heart is beating faster. Bradycardia is the heart is beating slower. So less than 100 beats per minute or greater than 100 beats per minute is tachycardia. Bradycardia is less than 60. Having said that, some people may have a low pulse, and they're normal low, usually athletes. They can have pulses of 50, and that's normal for them. So we don't panic. We ask them what is normal for them. I have a girlfriend who has an extremely low blood pressure. And every time she goes to the doctor, a new physician, she has to tell them, otherwise they panic. Because her blood pressure is approximately, what did she say the last one was? 80/60 or something. It's really low. And the poor people thought she was dying. Okay. So weak or thready lacks fullness. Full or bounding, so that's real. And imperceptible, really difficult to find. So here's heart rate, normal heart rate. Infants, 120 to 160, toddlers, 90 to 140. So school agers, so adolescent and then adult, 60 to 100, that's your normal range. Remember, in radiation therapy, we treat everybody. You can, depending on which department you work in, you can treat anything from infants to geriatrics. The youngest I've treated was 3 months. The oldest was 105. So, yeah. So you have to know whether you don't need to know, you don't need to know the actual heart rates, but you need to know that infants would be higher. Remember that for CPR? Yeah. Everybody's managed to be up to date on CPR? Yeah? No?
No, I need to get that done.
Yeah.
I couldn't do it during COVID, and now I think they're opening them back up now,
Yeah.
right?
Officially, you don't need your CPR till you go into clinicals. So this semester is not quite as critical, shall we say.
But I think they're doing them again, right?
I think so.
The last time I looked, it looked like they were open again.
Yeah, there's
Yeah.
classes open.
Yeah.
Yeah.
So I'll get on that.
Are you
Yeah.
a specific place you're talking about?
What?
Which place are you talking about?
I just went online for, when I first started looking for it, I just looked for the one for healthcare
Yeah.
workers, and they weren't doing them at the time that I was looking.
Right,
That was,
yeah.
Just make sure it's through AHA.
AHA?
Yeah, American.
Yeah,
Heart
it has to be AHA and it
Okay.
has to be for healthcare providers.
Okay.
Do you notice elderly having a lower heart rate? I thought they tend to slow down a little bit.
They do, they
Okay.
do, yeah. The geriatrics tend to be low heart rate on the whole.
Right.
Yeah, it's difficult to generalize with these things, but yeah. As a rule, infants are higher. As you get older, it gets slower. But then, if you have a geriatric with a heart problem like tachycardia, then everything goes out the window. All your rules go out the window. So the elasticity pulse is obliterated with slight pressure, so you have to be careful. So a stethoscope. Everybody's seen a stethoscope, right? The bell and the diaphragm. There's two parts to it. The bell and the diaphragm. So the diaphragm is high-pitched sounds, bowel, lung, and heart sounds. And the bell is low-pitched sounds, heart and vascular sounds, applied bell lightly, yeah. So when you're doing blood pressure, you would use usually the diaphragm because it's easier to control. Okay, let's do this. Respirations. Okay. So inspiration and expiration. Inhalation, exhalation. Same thing. You can use inspiration or inhalation, expiration or exhalation, I really don't care. One or the other. Both mean the same. One's breathing out, one's breathing in. That is one respiration. Breathe out, breathe in. Breathe in, breathe out. That's one respiration. Normal breathing is active and passive. Women breathe thoracically, while men and young children breathe diaphragmatically, usually. So there's a difference between the sexes in that still. So again, saying at the bottom, access after taking pulse while still holding hands, so patient is unaware that you're counting respirations, because they can change it. So, respirations, 12 to 20 breaths per minute. Again, tachypnea, bradypnea, and apnea. Shortness of breath shown shallow and rapid. Shallow, rise and fall is minimal, normal is deep and even. If you're watching them and you're telling them that you're taking your respirations, they're going to alter it. It's just common sense. It's just normal people. They do tend to do that.
They're trying to appear healthy, breathe good, you know?
Yeah, exactly. So dyspnea is difficult or labile breathing. Chain stokes. Has anybody heard chain stokes? It's once you hear it or once you see it, you'll never forget it. Period of apnea at the end of each cycle. So alternating periods of apnea and hyperventilation, gradual increase and decrease in rate. A lot of patients that have got lung cancer can do chain stokes, and it's not good. It can be very difficult. And a lot of patients with lung cancer also have dyspnea. So if apnea is the absence of breathing, is that a problem? Yeah, if it goes on too long.
It's an irregularities.
Yeah, so sleep apnea would be the one thing that most people are used to looking at or hearing about. Sleep apnea is what? Say again? Yeah, basically, sleep apnea, you stop breathing and your brain sort of switches in, hopefully, and says, hey, breathe. And then you start to breathe again. That's the theory. But some people, that's why they have these CPAP things, to make sure that they're actually breathing. It could be very difficult to have them not breathe. Blood pressure. Okay. Systolic. The force exerted against the atrial wall as left ventricle contracts and pumps blood into the aorta. And diastolic. arterial pressure during ventricular relaxation when the heart is filling, minimum pressure in the arteries. So, factors affecting blood pressure. The lower during sleep, lower with blood loss, change in position alters the blood pressure. So if you go have your MA or the RN at the doctor's office take your blood pressure, they'll take it sitting up and then ask you to lie down and maybe take it again. So if they take it first sitting, lying down and then ask you to sit up and you get dizzy, what's that called?
Vertigo. Is it vertigo? No.
No. It's called postural hypotension. Basically, it's the movement and your blood pressure sinks. Hypotension is low blood pressure. So if you're lying down for a long period of time, and this is sometimes our patients have this problem, they'll be lying down for 10 or 15 minutes and they sit up and the room starts spinning. And you just tell them to sit there until the room stops spinning. And that's what they call it, postural hypotension. So, positional changes, anything causing the vessels to dilate or constrict, like medications. If you're on medications or the patient is on medications that alter the blood pressure. So if the patient has high blood pressure and on medication to lower the blood pressure, then you have to know about that, because otherwise you don't know. Okay, so measured in millimeters of mercury, normal range is, systolic is always the higher one, diastolic is the lower one. There's a little controversy about what these numbers should be. Theoretically and historically, the average was 120 over 90. That was the high normal, 120 over 90. Several years ago, the College of Physicians decided in their infinite wisdom that they would put the systolic down to 110 and the diastolic down to 70-ish. That meant that several 100,000 people were now high blood pressure. And there were some people who could not get down to 110. So now they've moved it back up to 120 over 90. So if you have 120 over 90, you're good, but you're on the high side of normal. Put it that way. 140, that would be high. So hypertensive, 160 over 90. And hypotensive is 90. If you have 160 over 90, you need to see somebody about that. Does anybody know their blood pressure? And? Is it high, low, or in the
I
middle?
I usually range between like the 110s and 120s.
Okay.
Over 70s.
That's pretty good.
I range in the
Lately
normal
it's
range
80s.
too.
Most people your ages, guys, sorry, are usually in the middle range. Unless you have some underlying health condition that makes your blood pressure go up, except for exams and stuff like that, but everybody's blood pressure goes up. So 3 types, okay. So non-invasive method of blood pressure. So a sphygmomanometer and a stethoscope. 3 types of sphygmometers. An aneroid, which is a glass enclosed circular gauge with needle that registers the blood pressure that sends the calibrations on the dial. The mercury, the glass tube, you've seen the old ones where the glass tube sits about here and it's on the wall, and the aneroid are usually the round glass, they're about this size, on the cuff. And then the electronic one, which everybody now uses, which is good, but it's not as accurate. So a cuff, inflatable rubber bladder. That's there. Tube connects to the manometer, another to the bulb. Important to have the correct cuff size, just what we said. The cuff, so if you have a problem with it, the cuff is too wide, the cuff's too narrow, the cuff is too loose. So there's an arrow on the cuff which should point to the artery down here. And if you have good veins, you can actually see them. I have really good veins. And if you have a too loose cuff, then it's going to go down your arm. If you have too tight, then it's going to constrict more than it should. So this is, listen for Korotokov sound, series of sounds created as the blood flows through the artery after it's been occluded with a cuff. Then cuff pressure is gradually released. So you pump up, you put the cuff on, you pump up to 20 millimeters above what you think it is. So approximately, I tend to do it to about 140. And then there's a little valve on the cuff. You slowly open the valve. And what are you listening for?
Thumping sound of
Start.
There's a sound,
Yeah.
there's a beat that comes on. That's your first one, that's your top number. And then you continue to open it until you don't hear it anymore. That's your lower number. Does that make sense? Okay, good. So do not take the blood pressure in an arm with a cast, an arm with an AV fistula, and an arm on the side of a mastectomy, RE, right or left mastectomy. Okay. Why not an arm with a cast?
It can already restrict blood flow, maybe?
Yeah, the cast is, although nobody means to do it, it does restrict the blood flow on there. So an AV fistula.
Is that a hole between them opening up?
Yeah, basically it's the joining of the arterial and venous supply. You really don't want to
That's
do
not
that.
good at all.
No, it's not good at all. Some people do have it though. And the other one is if you've had a mastectomy on one side or the other, you don't do the blood pressure. Anybody give me an idea why that is?
Because once you remove all that, the glandular tissue that gets all the blood supply, it will change where the blood goes,
Okay,
the volume.
yeah. There's another reason. So when you do a mastectomy, and we'll learn this semester, you normally take all the lymph nodes out. So if you take the lymph nodes out, that tends to make the blood supply a little bit strange because there's no lymph nodes there. So the blood supply tends to be a little bit not normal, shall we say. So that's why you don't, that's the same reason as you don't lift anything heavy. You've had a mastectomy on that side.
So if they've had a bilateral mastectomy, you take it on the
Then you
leg?
have a problem. Yeah, you can, if they have a bilateral mastectomy, which is not common, but it's done. Then you may want to take it elsewhere, like the femur. Or
Coloners.
if the person perhaps has had no nodes removed on one side, then you may take it on that side. So, decreased cardiac output, fluid volume excess, and fluid volume deficit. So, implementation, palpate brachial pulse. You should use the stethoscope for that. Position cuff 1 inch above the pulse, arm at the level of the heart, wrap snugly around the arm, and the mamometer, which is the scale, at eye level. And make sure that the arm is comfortable. So have it sitting somewhere. So inflate cuff while palpating the brachial artery, note reading at the pulse. When the pulse disappears, continue to inflate cuff 30 millimeters above this point. So you start deflating the cuff slowly, and note when it's reading this pulse is felt. Deflate the cuff completely, wait 30 seconds. Okay. So close the valve, inflate the cuff now. So you basically hear the sounds, deflate it even further, they disappear, that's your 2 levels. And it's actually quite well described in the book there. Lower extremity if you have to. Not very common, but if you have to. Best position prone, if not supine with knees slightly flexed. Popliteal artery. So instead of doing it in the elbow, you do it in the knee. So it's easier if you can put them prone. Makes sense. So a large cuff, obviously. Same thing. Pulse ox. We wouldn't do this too much in the department. So what's a pulse ox? Pulse oximetry. What is that?
It's the amount of oxygen in your blood.
Amount of oxygen in the blood. So how do you do that?
The finger?
They have those little things, pulse oximeter,
Yeah. And what do you do with it?
put it on the finger,
Yeah. So you have a little box.
the little red light.
And you have a little, like a clothes peg, I guess, that goes onto your finger. And you can do it that way.
How exactly does it read the oxygen level though? How does it, what is the
It
sign
reads,
on
I believe it reads a saturation of oxygen in the blood.
I think it has something to do with the light in it, I
Yeah,
can't
shoots a
remember.
light through it,
Yeah,
reads, I guess it changes.
The one thing that you have to be careful of if you're using the pulse oximeter, can anybody tell me what?
nail polish.
Nail polish is one. Also, sorry?
Thickens nails.
Yeah. So nail polish is one, artificial nails is another. You should not. pulse ox won't work if you have an artificial nail.
So
or
maybe the
even-
light has to go through,
Yeah.
all the way through the finger and it
That's right.
detects
Yeah.
the darkness of the
So
blood
you
based on
can-
your iron levels?
Yeah, you can't do it with either colored nail polish or artificial nails. So, some people do it on the toe.
Oh,
If
yeah,
you
I
have,
see.
if you have no nail polish on the toe, which helps, yeah. So, yeah,
No matter which toe.
usually the big toe, but it really, would, what they would tend to do if you were in an emergent situation, they would just take the nail polish off of your finger. It's usually this finger that they do it, and they just take the polish off. And if it was an artificial nail, I've seen them take the nail off, the artificial nail off. Because if it's an emergent situation, sorry, you gotta do it. Oops. What was that?
The slide.
Oh, it's this. I'm sorry.
I thought you asked us a question, I was like, what?
I know that I was looking at this, the other day when I was going through it, and I'm thinking, I have to remember that does that.
Is that breathing sounds it's doing? What is that?
It's pulse on.
It's supposed to be the heart pushing the blood
It
through.
always sounded like
Oh,
clapping to me.
Oh, maybe is it the syndrome?
Yeah.
Weird.
Yeah.
I've never heard sounds associated with pulse ox before.
Yeah, well, anyway, so you can, normally 90 to 100. Everybody here should have 100 pulse ox. Most people do. 95 to 100. For some reason, men tend to be lower than the ladies tend to be higher. And I'm not going, I'm not going to go any further than that.
We're not good at breathing.
Yeah, so remove the nail polish or remove the nails. So you put the little peg on, I call it a clothes peg, same thing. And you can get it quite easily. So, assessment, route of temperature. So PO, tympanic, axillary, rectal. So you want to make sure that the patient has nothing hot or cold to drink or smoked. Smoking can change the temperature. Thermometer, watch, stethoscope, blood pressure cuff, and graphic sheet. And wash hands, of course. So, of course, you tell the patient what you're doing. You don't attack them with something and then say, okay, sorry. And most people are used to being attacked by thermometers and blood pressure cuffs as soon as they walk in the door of the hospital or work in the door of the doctor's office. So most people are used to having anything. Sorry. Yeah. Ew is right. Yeah. Let's see what this is. Again, this is a medical assisting thing, so. So febrile versus afebrile. Measure degrees in temperature in Fahrenheit or Celsius. Same thing. So here's your normals in both Celsius and Fahrenheit. 98.6 for oral, 37 for in Celsius. Tympanic, 99.6, 37.6. rectal 99.6 and 37.6. And axilla 97.6 and 36.6. So if you're asked what should the normal temperature be, you have to decide which one you're gonna use. You're gonna use 98.6, which is what everybody quotes. But if you're using that, you have to specify what route it is. So if you're gonna say the average is 98.6 Fahrenheit, 37.0 Celsius, you have to do oral. You have to put somewhere that is oral temperature, because otherwise you'll be marked wrong. And the rectal is the most accurate. More messy, but accurate. Yeah. Most people would probably not have a rectal temperature that very much. So oral or tympanic or axillary. It has changed somewhat because it used to be the normal route to do temperature would be axillary. Stick something under your arm and say, hold it there. But now it's an oral. But again, it depends on how cooperative your patient is and what age your patient is. So here's your fancy dancy little machine. Under the tongue in either pocket, just off center in lower jaw. So usually just under the tongue. And rectal temperature, well, obviously, gloves are done. Patient is positioned on side, left side preferred, or on stomach. Lubricated tip, always a good idea, of thermometer is slowly and gently inserted into the anus, half an inch for infants, an inch for adults. Hold thermometer in place while temperature is taken. And the axilla. So age, potential for injuries, proper technique, and OSHA and HIPAA. So you're about to take a temperature of a 6-month-old infant being seen in the pediatric or pediatrician's office for vomiting and diarrhea. What route will you use and why? And what are the special considerations to keep in mind for the specific patient situation? So what route? Not rectal.
I know,
I would do
oral.
axillary if you don't have it.
Ear?
I'd probably do
Or
ear.
about the ear?
Yeah.
Or the little thing that goes across the forehead? Or in these days, it's the automatic one that you stick there. Yeah. And what are the special considerations? Specific patient situation.
The vomiting and diarrhea.
Vomiting and diarrhea. So is that why you wouldn't do rectal? Okay. Yeah, it gets kind of messy. Right, okay, let's see what they say. 6-month-old will not be able to hold the thermometer under the tongue, so we use tympanic. Take temperature after the pulse and respirations. Use proper technique to pull the ear down and follow OSHA guidelines to prevent the spread of microorganisms because the patient is throwing up and having diarrhea. Okay. Pulse and respirations are linked since the heart and lung functions together. So pulse, radial artery is a common site, but brachial artery is used in young children, infants mainly, for brachial artery. And the stethoscope is used to take the apical.
What does that mean, pulse, the thumb has a pulse of its own? What does that mean exactly? Don't all
Sorry,
your
say
fingers-
again?
What does it mean that the thumb has a pulse of its own? Don't all your fingers have a pulse? I mean, don't you have a pulse?
The thumb is closest to the skin.
Okay.
So if you put, the way I was taught many years ago was this. So you have the thumb at the back, just to help, thumb at the back, 2 fingers there. That is wrong, because in that case, you may hear your own pulse.
So you're not supposed to put your thumb on it all.
No, you keep your thumb out of the way these days. It used to be that you could do this. But nowadays, you do this.
But if you're taking your own pulse, does it matter?
Yeah, because it would get confusing if you're trying to, you get 2 pulses basically.
They might be like a split second off, just because they're traveling, the blood traveling.
Yeah.
Yeah.
So the idea is to do it, as easily as is humanly possible. So if you just use your 2 fingers, make sure you have your, don't try, as I say, do this and then do this. That's why when somebody was doing the pulse, that's why the older nurses had what they call a fob watch, which is a watch that used to hang, so something like this.
I've seen that.
And it was upside down. So the nurses could take the pulse with one hand and look down and see second hand going around. I got one as a birthday present when I graduated. Anyway, but because we weren't officially allowed to use watches, wrist watches. So here's the, okay, so a regular pulse rhythm, count for 30 seconds and multiply by 2. Count for the irregular pulse, so you see you've got these and then you've got a gap. So these, you've got good, and then you've got a little strange gap here, and then you've got another little gap here, and another one and another one. This is the irregular pulse rhythm. So here, you would count for 1 minute and just explain that it was irregular. So respiration, here's your normal respiration, and there's your answer for respirations. Elderly, doesn't specify what elderly is these days, so elderly would be a little higher range than the actual adults. So you notice that 11 to 16 is 16 to 24. You get to elderly, it would be 12 to 24. So the range is slightly expanded. Taking respiration, we've already gone over that. Breathing abnormalities, apnea, dyspnea, and hypernemia, and tachypnea. Okay, 26-year-old athlete visits the medical office. The temperature is 98.8, pulse is 52, and respirations is 18. So what should you do about those results?
I think he's
They're all normal.
they're an athlete.
Because you're an athlete, it's normal for him or her, yeah. So with the athlete, the pulse of 52, yeah. So again, blood pressure, systolic, diastolic, and 120 over, in this case, they're saying 80. So systolic is always the higher, diastolic is always the lower. And in some urgent cases, like perhaps in a trauma center, you might get the paramedic saying blood pressure is 90 by palpation. So they don't have two figures, they only have one. And that's a bad sign. That means something. That means they're probably bleeding out and they really need some help. Hypertension is high blood pressure. Major contributor to heart attacks and strokes. Low blood pressure, not a chronic health problem, and as I said before, normal for some patients. Severe low blood pressure readings occur with some stroke, heart failure, severe burns, and excessive bleeding. Some people just have low blood pressure. And there's really not a lot you can do. So the sphygmomanometer, we've already explained that. So this is the old-fashioned one. You don't see these much in doctor's offices anymore. So this is the actual mamometer here, and the cuff. Normally, nowadays, they have a little round gauge on the cuff that you can see. And again, so this is the electronic one. Yeah. So the rubber, the bell and the diaphragm. And we'll go over some more of that later. And here's another one. So wait 15 minutes before taking readings if patient has been engaged in strenuous exercise or has ambulatory disabilities. Be sure the cuff is properly fitted so it's not too tight or too loose, and injury or blocked artery is present. Mastectomy or implanted device under the skin. So pacemaker or defibrillator, you can actually defibrillators, not defibrillators on the skin. So if I have a pacemaker implanted, where would it be? Where would you find it? Anybody, any
Near
ideas?
the clavicle. Can't remember if it's under the clavicle or over the clavicle, but it's near that area. I had a friend that had one.
It's actually about, usually about here, and it's actually over the clavicle. Yeah, so it's somewhere around about here. And that's the actual device, but the cables go into the heart. So we have to be careful of that too. And we want to make sure that we're not treating over the pacemaker. We cannot treat over a pacemaker. If we're treating anywhere else in the body, we have to do this pacemaker protocol, which can be as little as doing pressure, temperature, and pulse, or it can be blood pressure. And theoretically, if you need to treat over there, the pacemaker has to be moved. Because you cannot treat over a pacemaker. It would not survive. And we also, for the pacemaker, we have to make sure that we contact the manufacturer, because there's only so much dose that the pacemaker can take before it stops working. That's why if we have to treat over it, it has to be moved. and that's not a easy procedure. Okay, so a 67-year-old patient is the medical office complaining of a headache. The blood pressure, the blood pressure reading is 212 over 142. What should the medical assistant do in that situation?
Call an ambulance.
Apart from panic?
Hospital.
Yeah.
Alert the physician and probably
Alert
send them
the
over to the
physician,
ER.
yeah. Yeah, send the patient to the ER. The blood pressure reading is 212 over 142. I would say it probably needs to be repeated, just to make sure. On the other arm if necessary, in a different position if necessary. But that
No bueno.
would have to be done again, just to make sure. But if that is what it is, then complaining of headache should be reported to the physician. Recall that hypertension is a major contributor to stroke and heart attack. More likely to be stroke. What's the correct name for a stroke?
Ischemia?
Pardon?
Ischemia?
No. It's called a cerebrovascular accident, or a CVA. So body measurements, obviously height and weight. Like nobody gets away with not getting their weight done in the adult. So if you go into a physician's office and they say that your weight is 90 kilos, what is that in pounds? And how would you change that? How would you find out what it is in pounds?
Like 2.2 pounds?
2.2 pounds, so 90 kilos is what? Say again?
180 something,
100,
80 something.
more than that, actually.
190.
I'll have to check. I don't have my calculator with
You made it.
I feel like I should be able to do this.
me. It should be about 198,
198.
198.
I just know that because all the places just put kg on
Yeah. So in most doctors' offices still, they're doing it in pounds. But in some cancer centers, they will weigh in kilos. So I remember one of the departments I worked in, they wanted to change from pounds to kilos. And the doc said, we're not changing to kilos until all of our patients know what kilos are. And we never did change the kilos. Yeah. Okay, medical assistant is about to weigh a 6-month-old infant using the infant scale. When the medical assistant places the infant on the scale, she notices that the diaper is very soiled. Ugh, okay. What should she do?
Give that baby back to mom. Tell mom to clean it up and take it off.
That's white.
What?
Yeah, that's white.
Okay,
Strip it down.
Wait a baby naked.
well,
You have to weigh both of them.
yeah, so what you would do, and what it says here, if I remember correctly, I remember this one, is that you weigh the baby, diaper and all, then you take off the diaper and weigh the diaper. So then you have the weight of the baby. Which I thought was really good, but anyway, I'm with you, I think I'd give it back.
We always just have them
Changer.
weighed naked. I don't understand why the whole extra step.
Yeah. So questions on vital signs? So how often do you think we would weigh or do vital signs on a patient?
Every visit, I would think.
Before and after.
No,
No?
we do vital signs usually when they're going to see, the physician sees the patients once a week. They must see the patient once a week. So normally what is done is that the patient goes to see the doctor, the nurse is in the room, he or she will do the vital signs and have them in the record for the physician to see. Weight, however, is also done once a week, and we usually do that. Unless the physician specifies that it has to be done more than once a week. So everything is done once a week, unless specifically told otherwise. So things like patients that are being treated with head and neck cancers, you'll probably weigh them more than once a week because they're apt to lose a lot of weight very quickly. But normally it would be once a week. That would be a standing order for the patient.
Do doctors see patients pretty much on the same day every week, or are we seeing, if their doctors spread them out through the week, technically we would be doing vitals every day, wouldn't we?
Well, we would not be doing vitals. The nurses would do the vitals when they take them in to see the doctor. So it depends on the physician. Normally, if you have one or two physicians, they would see their patients on a Wednesday or a Thursday. Or somebody might see their morning ones on a Wednesday morning and their afternoon ones on a Thursday afternoon. And the other physician would see them, the morning ones on a Thursday morning and the afternoon ones on Wednesday afternoon, something like that. So, and if you've got more than one or two physicians, then you have to, may have two doctors seeing their patients in the mornings on a Monday or mornings on a Tuesday or whatever it has to be. Then you have to remember which doctors are seeing patients and which days. But normally if you have one or two doctors, it's easy.
So we only do vitals if it's special requested or if it's the day that they're
The
seeing them.
nurses do vitals.
So we don't do them at all?
Unless there's something specific, like unless you have no nurse in the building, then you would do vitals. And that's why you need to know how to do vitals. If the patient has a pacemaker, then you would do the pulse before and after. Or you would do the blood pressure before and after, depending on what the protocol is for that particular department. Or if there's an emergency, if your patient suddenly goes loss of consciousness or they're not being as talkative as they should be and you think they're going downhill, then you may take their pulse and respirations and call for help. How would you call for help without panicking the rest of the department? Or especially the rest of the patients? You don't go out of the room and yell for help, do you? So how would you go about getting help?
Grab a nearby employee.
Does the physician have like a phone in his office? I mean, or a
Yeah, but they may not be there.
Channel.
Sorry?
Call it code.
No, you don't want to call a code at this point, no.
Call
Yeah, what you would do is you would, if you have an overhead system, you would call RN to Linac 1 stat or physician to Linac 1 stat. And that means that you need somebody now. Otherwise, you can call their office, but 9 times out of 10, you'll never get a doctor in his office. Or, you know, if you know there's a nurse in her office and they're fairly close, then you go running and get one. But the one that I remember many years ago was in Calgary, and we had a patient come down from, we had nursing units, oncology nursing units in the hospital, which were 5 floors above us, because we were in the basement, they were up. And, or the ground floor, I should say, but they were up. And this particular patient, we were treating his brain. He was a brain mets from bronchus. And he came down in a wheelchair. The porter and staff brought him down in a wheelchair, parked him outside the door. And I went to get him, to take him into the room, and he said, I have to go pee. So I said, okay, so I wheeled him around to the bathroom, opened the door for him, he went in, and I left the wheelchair locked in the corridor. And I said, I'll be back in a couple of minutes to check on you, which I did, to be met by blood coming out from underneath the door. And I thought, this is not good. And I tried the door and it opened. So I peeked in and all I could see was blood on the floor and the patient on the floor. And I thought, this is 8 o'clock in the morning. Yeah, what a way to start morning. And so I knew the nurses, the hallway was here, and there was another hallway here, and the nurse's office was right there. So I went barreling around, poked my head in and said, need help now, and went barreling back. And there was 4 nurses in there, and they all and they opened the door as best as they could, and they said, we need a doctor, you call. And I said, I'll do better than that, I'll go. I saw Dr. Arthur, who was the boss, in his office a couple of minutes ago, so I'll go get him. So I went barreling around, poked my head in the door, and I said, Dr. Arthur, need you, sat, bathroom, floor, here. And he looked, okay, and followed me. And we got the patient out of the room, onto a bed, onto a gurney, and into a treatment room, into a review room. And the nurse looked at the dog and said, do you want to call a code? And he said, no. He said he was dead before he hit the floor. So what had happened on this guy, and I'm glad it happened there and not, I hate to say it, but not on the bed, was that the tumor in his lung had eroded his aorta and he bled out. And once we got him situated, we sent him back upstairs to the ward. And Dr. Arthur looked at me and he said, go get yourself a cup of tea. And I said, I've got patients. Go get yourself a cup of tea. And he said, you're pale. And I said, oh no. And he said, yeah, and look at the shoes. You ruined my shoes.
Where was he bleeding out from? Did he have an opening in his chest?
No, he was bleeding basically from every orifice. He was bleeding out of his nose, his mouth, his anus, everywhere.
Wow.
So it was just blood all over the place. So we had to call housekeeping.
How does that just happen all at once?
What?
How does that just happen all at once?
Well, because it had gone into his aorta, and every time his heartbeat, all the blood came out of his aorta and out of basically everywhere.
So you definitely wasn't expecting that?
No, no, we wouldn't have got him down off the unit if we'd expecting it, because we were treating his brain. We weren't treating his lung.
Because it was a brain met.
It was a brain met from lung, yeah. So I looked down, and this brought me back to reality when Dr. Arthur said, "You hurt my shoes." And I said, "You did that on purpose." "Yeah." He had suede shoes on, and the blood had just come down and literally had ruined his shoes. So, "You realize my wife is gonna give you trouble." And I said, "Sure." Anyway, that's my story. That's basically what you have to be careful of. And hopefully you'll never see anything quite like that. I hope I never see anything quite like that again. But you have to be prepared for something like that. Not as common as that, but these things happen. Okay, on that joyful note, I will send you to lunch.